I'm Andrew Miller. I'm here to talk about our paper from the November 2021 issue of Respiratory Care titled Prevalence of Burnout Among Respiratory Therapists Amid the COVID-19 Pandemic. A little bit about me. I'm a respiratory therapist and ECMO specialist at Duke University Medical Center, and I also chair our department's research committee. Conflict of interest. I am currently the section editor for pediatrics for respiratory care, but I have no other conflict of interest. As we know, burnout is a major challenge in healthcare. We have recent data that suggests that burnout rates have increased due to COVID-19, and they've increased about 11% in critical care nurses from 60% to 71%, and increased about 7% in physicians, which is also a significant increase. But unfortunately, we have limited data in respiratory therapists. There have been some studies that included RTs, but they're usually in kind of an other pool and not specifically reported. So we really need good data on what the RT prevalence of burnout is. So the purpose of our study was to determine RT burnout prevalence and identify risk factors that are associated with burnout. And how we did our study was we developed a survey. We then administered it to 26 different centers. We distributed it to the individual department leadership, which means that we contacted managers and directors at various departments who then sent out the survey to their staff. In order to identify a representative sample, we tried to identify at least 5 academic centers, 5 children's hospitals, and 5 community hospitals. And then we used validated surveys for burnout and leadership. These are from the SCORE survey. Those are available online if you'd like to look into it more. And then we also asked additional questions about staffing, demographics, and center characteristics. And then statistical analysis, we compared continuous data using the Mann-Whitney test, categorical data via the chi-square, and then we performed a multivariable logistic regression to identify risk factors for burnout. And on to our results. So we had 1,156 responses. The response rate was 37%. This is a little bit lower than what we would like for this type of work, as the respondents may have had a special interest in burnout, which could have skewed the results a little bit. But what we found was 79%, which is almost 4 out of 5 RTs were suffering from burnout. So 10% had severe burnout, 32% had moderate burnout, and 37% had mild burnout. And then what we see here, the hospital demographics, so these hospitals are fairly large. The median vacancy rate was around 7%. And what I want to really point out here is that most RTs had a positive view of their leadership, but most were suffering from burnout. But then what's really important here is these bottom 2 numbers, is that the range of department burnout rates was 53 to 100%. And then when you ask people, are the other people you work with burned out, this was 88% and ranged from 42 to 92%. So this is representing that RTs really think that people are burned out and they themselves are suffering from burnout. Then when we compared people with burnout to those without burnout, people with burnout worked more hours per week in the ICU, were less likely to work at an academic center, more likely to work with adult patients, and delivered more care via respiratory care protocol. And on to more results. So there were significant differences for staffing, ability to finish the work each shift, COVID-19 exposure, leadership score, missing work for any reason, missing work due to illness, and then all individual burnout responses were significantly different between those with burnout and those without. And then the burnout climate, which is a simple question where we asked people, do you agree or disagree with people in this work setting are burned out, is how we determined the burnout climate, and that was also statistically significantly different. Yes, and on to our logistic regression results. So these are the risk factors that we've considered to be independently associated with burnout. And so things that we found that were associated with an increased risk of burnout were inadequate staffing, and this was an odds ratio of 2.1 to 3.2, inability to complete assigned work, which was associated with an odds ratio of 2.1 to 5.6, burnout climate, which was associated with an odds ratio of 9.4, and missing work for any reason was associated with an odds ratio of 2.0. And then things that were protective against burnout or reduced your risk of having burnout were not providing patient care and then having a positive view of your leadership. So if you had a positive leadership score, you were less likely to be burned out. And then things that became non-significant in our multivariable analysis were COVID-19 exposure, hours worked per week in the ICU, commute time, RT protocol use, highest degree earned, shift work, role within the department, and activities restricted due to illness. A little discussion. So what we found was burnout was actually higher among RTs than what has been reported in other professions. And then staffing and workload had large effects on burnout. So these seem to be the major drivers, along with leadership and burnout climate. So these seems to be the main drivers of burnout. And leadership rounding has been associated with a decrease in burnout. So that's one strategy that leadership could consider. And then surprisingly, COVID-19 was not associated with burnout. No study is complete without a list of limitations. Our respondents may have had a special interest in burnout. They may not have been a representative sample of RTs in general, and we didn't include centers outside the United States, so we can't generalize these results to RTs working outside of the United States. And in conclusion, burnout was common among RTs in the midst of the COVID-19 pandemic, and further studies are needed to evaluate factors associated with burnout and specifically investigate interventions that may reduce burnout. Thank you.